Hi, welcome to Victim to Victory, the definitive authority in personal injury. Today, we're fortunate to have our guest, Dr. Timothy Roberts. He is board certified in orthopedic surgery, went to uh, Cleveland Clinic and studied both neurology as well as orthopedic surgery. And he's done a lot of clinical research and made over 50 publications. He is now with New York Spine Institute as well as New Jersey Spinal Associates. Welcome to the show.
Thank you for having me.
Just before getting here, he actually performed a fusion surgery as well as a couple microdiscectomies. Now, doctor, we're going to talk a little bit about trauma since that's what we do a lot of in the personal injury realm. But please tell us a little bit before we get there about some of the clinical research you did and when you studied both neurology and orthopedic surgery.
Sure. Well, the research I've done is primarily in spinal injuries, and studied different ways of treating those injuries, different ways to classify those injuries, and then study the different ways in different outcomes from different surgeries. Um, a lot of the other research that I've did, and not so much lately, but certainly during my training and during my education, was studying a condition called osteogenesis imperfecta, which I'm sure we'll get into, but it's a condition that I myself was born with, and ultimately kind of led to my path getting into orthopedics.
Wow. Why don't you tell us a little bit about that condition?
So some people know it as OI, or osteogenesis imperfecta, and it's a condition, a genetic condition one's born with that leads to the formation of brittle bones. So as a child, I had, I think, 50, maybe 60 fractures. Um, Talking a lot about sports, but, I could never play sports. I could never run or do anything too athletic without injuring myself. And I had so many fractures that my legs actually began to kind of grow at funny angles. And so I had a life-changing surgery. I don't think that's overstating it. When I was maybe 10 or so, where they actually had broken my legs and then, put some, well, we call it rotting, but basically putting some nails down to straighten it. And that was enormous for me. I mean, as a kid, when you're super worried about what everyone else thinks, it was a big thing. I could wear shorts again without having obvious deformities. I could start to at least do some light jogging and doing, I remember getting out on the soccer pitch with some of my friends, and even though it was terrible, it was just nice to at least play along.
Wow. And so you did some research in that.
I did, yeah. During medical school, I had a summer and I spent it at Johns Hopkins in a division of their institute called Kennedy Krieger. And actually, it was very cool because I was part of a group that was studying type 5 OI, which is a very rare version of it. It's actually the version I had. And for a long time, without getting too into the details, but it was a condition where we did not know the mutation that caused it. Typically, the majority of the cases of OI formed by a collagen issue, where collagen is kind of the organic, or the kind of the rubbery part of bones, and then calcium and phosphate fill it in and kind of make it, make it strong. It's kind of like the rebar and then cement when you're building the building. So the vast majority comes from that, but they tested us, multiple times, and our collagen was totally fine. But we eventually rounded up, I think, maybe 23 other individuals across the country that had it, and collected their samples, and or was part of the team. Actually, another team didn't beat us to it, but we were the second to confirm the mutation that caused it, which was really cool to grow up with this thing that was kind of a mystery. No one really knew what was causing it, and then to at least play a small part in helping find the cause.
And it's amazing that you can still do all these surgeries and be on your feet for long hours with this condition.
Yeah. There was, I had a couple of really long talks with some of my doctors and some of my mentors about, hey, do you really want to make the 10-year investment into this field if, you are at risk of being injured and nothing ever do it? Or or just not being able to keep up. So it was a very real, real consideration that I remember sitting down with parents and having long talks about it. But thank God, it's been just fine.
So then you had to go over and above and beyond by not only doing the clinical research, but then studying both neurology and orthopedic surgery. So tell us a little bit about the difference between a neurologist's approach to the spine and that an orthopedist's approach to the spine.
Yeah. So the program I did was a combined orthopedic and neurosurgical spine surgery program at Cleveland Clinic, which was fantastic because I got to work with, as you can imagine, neurosurgeons and orthopedic surgeons who both generally treat the same kind of conditions, but both bring very different skill sets to the table. Doing full 5 years of regular orthopedic surgery or general orthopedic surgery, you get to be very adept working with bones and muscle and different soft tissues. But you don't really spend much time, say, suturing nerves, working around neural structures and those things. And then similarly from my neurosurgical colleagues who are excellent at operating on nerves and doing a lot of extraordinarily fine detail, but don't necessarily have the the knowledge or the experience with working with bones. So yeah, this was a fantastic program in Cleveland that allowed you to operate with experts in both fields, and they'd share all their tricks of the trade and all their knowledge and different techniques with you. And yeah, I felt like it was an extremely thorough, well-rounded education. And I think now, when we do encounter nerve issues, even though it is technically, still beyond the scope of what we do, I feel a lot more comfortable managing those issues because of it.
Sure. Now, even back when you were going to Tufts for medical school, you actually wrote a book on like a primer on orthopedic surgery or what to expect when you're going to school to study orthopedics.
Yeah, yeah. That was the first year of my internship. One of my favorite books as a medical student was the case file series, which instead of being a traditional textbook where it would lay everything out, it would give you, a small blurb about a, 45-year-old patient comes in with kind of abdominal pain and this and that, and then you would put it together, answering questions along the way. And at least for me, easily distracted, not probably have some ADHD. Wherever it was a little more personal and case-based, it always seemed to stick better. But there was never a book for orthopedics. They had a lot of the other specialties, but they didn't. So we had written a sample chapter. I think it was based on tibial plateau fractures, and we sent it to the author, who could not have been more gracious, and was more than happy to have us involved, and said, "Okay, put the book together."
That's awesome. All right, now let's get to the clinical practice. You got to do a little research on OI, which was the condition that you suffer from. You overcame that through surgery, and I guess that's really what focused you on getting into medicine. So now that you become a doctor and you're performing surgery, let's talk a little about traumas and fractures and how important it is if there's some neural compression to get somebody into the OR quickly and why.
Yeah, absolutely. So I take a reasonable amount of call at Jamaica Hospital in New York, which is a pretty major trauma center, and we see a lot of motor vehicle accidents, gunshot wounds, penetrating trauma, and yeah, one of the things that'll wake you up at 3 a.m. and get you into the hospital are often spinal cord injuries, specifically partial injuries, where there's a very good chance that if you act quickly, you can often restore or at least substantially improve the patient's chances of having normal neurological function. Right. So that would be, broken necks or dislocated necks, anything in the thoracic spine and sometimes in the upper lumbar spine.
There's also something called cauda syndrome, which if somebody severely herniates a disc in their low back and it puts pressure on the neural elements, and we all know, well, This does, I know you know this, but our spine turns like into a horse's tail in the lumbar spine, and it's not that solid cord that it is in the thoracic and in the neck area or cervical spine. So, what is caudal equina syndrome, and why is it so important to get that taken care of immediately if there's some neural compression?
Yeah, tragic condition, fortunately quite rare, but yes, just been described perfectly. At the right at the base of the thoracic spine, the actual spinal cord will end, but then it branches out into a whole bunch of these different little rootlets, which look like a horse's tail. We call it equina. And a large herniated disc, or sometimes like a hematoma, a blood clot, or infection, can put enough pressure on that sac containing the nerve rootlets that they basically all get kind of kinked off and stop functioning. And fortunately, it doesn't. It can often spare your arms, and depending where it is, it can spare your legs. But there's a lot of other functions that people don't even necessarily think about: bowel function, bladder function, sexual function, and all that stuff. So patients not only will have an extreme amount of pain, discomfort known as tingling, that suddenly will feel like they've lost control of their balance. So the solution to that is getting in there as soon as possible, or at least as soon as safe as possible, and getting the pressure off those nerves. Because the longer they have pressure on them, the higher the chance that they may not regenerate or might not come back to life.
Sure. Let's talk about ER. We talked a little bit about ER traumas, gunshot wounds, and traumas. How do you triage a case like that? What somebody comes in, they're in a severe fall or a collision. How do you triage it? What are you looking for if they're complaining of I have severe spinal cord pain, back pain, pain going down my legs? What is the system in the hospital if you see them?
Yeah. Well, look, fortunately, a lot of those patients are managed by ER staff and trauma surgeons, people a lot smarter than me, that are already at the door when they come in. But anytime that they will diagnose, major spinal trauma, or if I'm on general orthopedic call, other lung bone fracture or leg injuries, we'll get called in to evaluate the patient, and certainly depends on what the condition of the patient is. So a lot of the time, these patients are either unconscious from the accident, or they're deliberately made unconscious, so they put on they're intubated and put on a respirator for whatever reason. But it's very important to get a good history, if you can, from the patient. So what hurts, let's examine every party. We'll get to what, the number one thing, but so many times there'll be missed injuries. So there's a phenomenon called the distracting injury syndrome, where basically one thing hurts so much you don't even notice that your shoulder's dislocated or whatever. And so it's extremely important to get a good examination. Up to, I think it's maybe 30-40%. Somebody comes in with a lumbar fracture, there's a very good chance that they've got another fracture somewhere else in their spine, especially if they say fell from a height. Like the big axial impact it's going to shatter one vertebrae, it's probably going to hurt a couple others too. So, you want to have a very high clinical suspicion. I think we'll be very, very thorough and evaluate all these other injuries, and then obviously get to the main reason that you're there.
Let's talk about some of the surgeries you do. Although I know most of the time people do very well with just conservative care, whether it's physical therapy and pain management, and they don't often need the surgery. But when they do need a surgery, what types of surgeries do you perform, and why would you do a minimally invasive discectomy as opposed to a fusion?
Yeah, great question. So, I think your first point is absolutely is really important. So, a lot of these people do actually get better with conservative treatment, with physical therapy, sometimes some injections, anti-inflammatories. And one of the biggest things we say or see is patients coming in is like, well, I'm seeing a surgeon. Do I need a surgery? Not necessarily. A lot of time we can treat these things effectively for long term with more simple, safer, cheaper solutions. But when it does come to surgery, the kinds of procedures that I'll perform are, so we'll do discectomies, where basically we're shaving back or trimming back a bulging or herniated disc to take pressure off a nerve. sometimes we'll do something a little bit bigger called a laminectomy, where you remove, this is mainly for the lumbar spine, but you remove a little shelf of bone from the back of the spine. So you let the nerves kind of breathe a little bit so they're not getting squeezed up against a bulging disc, let's say. And then a little bit more extreme, but sometimes the pathology will call for it, is something called a fusion. So you actually go in and work around the nerves and remove whatever's left of that damaged dead disc, and then often put a spacer or something between the bones to hold them in the right alignment, and then a couple of screws or there's other fixation devices to hold it together while it heals. And basically what you're doing is just like when you break your arm, you've got two raw bone surfaces there that your body knows to heal back together. So we'll put those, in a cast, give it 6 weeks, and then take it off, and you get your function back. So what we're doing with a fusion surgery is basically roughing up the bone edges and tricking the body into healing those two bones together like it's a broken bone. Often there's some screws or rods or plates to hold it still. But the benefit of that is you can get up, get moving, move the rest of your body while that one segment or two segments are held together. A lot of people don't realize that later you can actually take that stuff out. You don't need to leave it in. Because once the bone heals together, that's going to take all the force, and the spurs become pretty much redundant.
How many people actually go in for that second surgery and have the screws removed?
Great question. So how many people think they want them out versus how many people actually get them taken out?
Right.
A lot of people, and I totally understand it, be like, oh yeah, if we could take it out, let's get it out of my body. And I think maybe not 3 or 4 times in 10 years.
Right.
Yeah.
It's very rare. I've been doing this now almost 40 years. I hear somebody going back in and having the hardware removed after having a fusion surgery. What are some of the other procedures that you can perform as opposed to a complete fusion? You talked a little bit about the microdiscectomies and the laminectomies. Is there anything else that you're doing? I know there's a lot of experiments now with disc replacement, and now there's even different types of fusions where no longer they used to be either a bone or a cadaver bone. What are some of the options now that can be used?
Yeah, so especially in the cervical spine, I will often perform what we call a cervical disc arthroplasty. So fusion's a great surgery. It's tried and true. It's been around 50, 60 years with good, reliable results. But now we're starting to see 20, even 30-year data on these cervical disc arthroplasties, which do seem to work pretty darn well. And basically what you're doing is you're going to do the same discectomy where you remove damaged disc, take the pressure off the nerves. But instead of putting some bone graft in and screws, you put in a mechanical device that, even though it may not replicate the motion perfectly, you can at least still let some motion at that level. So the idea is twofold. One, it is to not end up with a stiffer neck than you would with a fusion. But there's also a phenomenon called adjacent segment disease, which when you fuse some levels together in the spine, you are asking more of the levels above and below, basically to compensate. And that can, in some situations, lead to them wearing out. So the idea also of doing the arthroplasty or the disc replacement is you can just allow the motion to be distributed along all the segments without overly stressing the one above.
Yeah, I find it pretty interesting with the new disc replacements where they're basically putting just a spike or a nail in the vertebrae above and the vertebrae below, and basically locking that disc into place just with a couple nails. Now, I'm probably using the wrong terminology, but what would you call them?
Well, yeah, I mean, so some of the earlier ones did have, a big kind of flange with a screw in it. And then now they'll have like a keel or basically a cut just to kind of stop. And some of the even more modern ones just kind of have this kind of what we call like a grip blasted ingrowth titanium, but it's basically just a very rough sandpaper on the surface that microscopically bone will actually grow into. And bone seems to love titanium for some reason, but it'll just grow right into it and think of it as its own material.
Talk about the future. What does the future of spinal surgery look like?
It's a great question. I certainly think arthroplasty is a big one. Okay. Back in the day, if you had bad hip or bad knee arthritis, the ultimate result, if you just couldn't walk on it, would be a fusion. You'd take up a knee joint and just basically get the bones healed together. You'd have an egg leg. And, it's obviously very difficult to sit down and function like that, but it's still better than having, a joint that's unstable or incredibly painful. Certainly, knee arthroplasty, hip arthroplasty, hip replacement surgery has come a long way in patients. They're doing them as outpatients now. And the results are great. They're reliable. They last 20, 30, 40 years, often outlasting their patients. In spine, I don't think we're there yet. So I think putting a more natural, more physiological device in to mimic the natural function of the body is a big leap. I think a lot of these cases, minimally invasive surgery has come a very long way, but it's still a lot of the time you're still admitting these patients to the hospital. They still need to stay. It's still it's a longer recovery process. Probably not what it was 10 years ago, but keeping the surgeries small and as pain-free as possible is another big area for innovation. And I'd say AI and robotics are coming a long way too. We do robot-assisted surgery sometimes. A lot of the time we're using some really cool technology where you're taking some preoperative CT scan or an MRI, and then right in the OR, you're syncing it up. You've got a little probe, and you can see around the MRI where you are. And that helps keep things smaller. And as a surgeon, it gives you a lot more confidence that you've got the whole herniation or the whole problem taken care of.
It's funny you mentioned AI because I was just listening to something. People going to med school, they're actually some of the experts are saying don't become a radiologist because the AI can read the films so much better and faster now. If they don't get tired, they can go through them so much but quicker. That may be a field that disappears.
Yeah. These are very bright, innovative people, and I'm certain they'll find a niche where they're still useful for sure. But yeah, unfortunately, that is probably the first major medical field to be affected by AI. Fortunately, what we do is still very hands-on. It's a hands-on approach, and it still requires us to be there. But I think if surgeons and all physicians aren't considering what an AI future looks like, not just for their patients, but for their careers, then they're certainly going to miss out.
I think not only do we have to worry about that in the medical profession, but also the legal profession too. It's in a lot of other professions as well. And it's amazing how fast AI is evolving. Let's talk a little about trial work. And every time there is an injury to the spine, if it's a herniated disc, the defense attorneys are going to claim it's either not there or it's degenerative in nature. How can you tell if something's degenerative or if it's traumatic in the spine?
Yeah. It's a great question. Something we deal with quite a bit, as you can imagine. Certainly on an MRI, there are some obvious telltale signs that something is clearly acute or subacute. Acute typically meaning within the last 6 weeks, subacute, being 1 to 3 months or so, maybe a little bit longer. So on certain MRI sequences, something called a stir or a T2, the image is going to light up and be a little bit brighter if there's fresh inflammation, we'll call edema. And a lot of times you'll see that right at the disc edge or right within the nucleus, which is kind of the soft gel within the disc. And if you see that, especially if you see it at one level and the rest look kind of darker or cold, then you can say, oh, pretty confidently that's clearly a fresh subacute or acute injury. And then the other thing is you want to consider the patient you're dealing with, right? So if you've got a 30-year-old patient, every disc in their spine looks pristine, and one's clearly inflamed and beat up, and they're in a car accident, I think that's pretty clear. That's a traumatic thing. The other thing I'll say is that a lot of patients, they did this very famous study where they took people right off the street that didn't have any disc, any back or neck pain, and they scanned them. And a lot of people do have herniations and, some wear and tear throughout the spine. So just the presence of that doesn't mean it's symptomatic or significant. You got to correlate it to what the patient's complaining of.
So even if somebody has herniations or bulges, if they're asymptomatic, can those be worsened or aggravated by trauma?
Oh, absolutely. Yeah.
And how can you tell if something that's aggravated? Is there any diagnostic studies that can tell if something's been aggravated or what we call acute?
Yeah. So, as I said, you sometimes see the inflammation on the imaging. I don't do them personally, but a lot of neurologists and PM&R doctors will do EMGs, and they can often distinguish it as an acute nerve irritation versus a chronic thing that's been going on forever. And then on a physical examination, you can learn, you still learn a ton about a patient. So if they've got weakness, numbness, tingling, or some sort of deficit in the area where, before their accident, they were walking, functioning just fine. So there's a lot you can, you have a lot of tools in the clinical toolbox to kind of figure out if something's brand new or if it's been around forever.
Now, talk to us a little bit about New York. Where do you have offices with New York Spine Institute?
Yeah, so we're started in New York by my boss many years ago, and we've recently been branching out in New Jersey, where we're known as New Jersey Spinal Associates, and we are currently in West Orange, and we are in Marlton, um, and we're probably expanding a little bit more too.
And if somebody wants to find you because they want a surgical consultation or they want to be treated for an orthopedic or neurological deficit in their neck or back, how do they contact you?
Yeah, if they Google New York Spine Institute, we should come right on up. Or give us a call at 516-357-8777.
I want to thank you, Dr. Timothy Roberts, for being here. Incredible interview, clinical studies, orthopedic, spine surgeon, board certified, as well as a background in neurosurgery. An incredible man, great surgeon. Thanks for being on the show.
Thanks for having me.